Hello everybody, today we will read about luteal phase defect. Definition. First, it is a condition in which ovarian hormone production is not a sufficient quantity. Second, it broadly refers to an abnormal luteal phase. Third, luteal phase defect refers to a luteal phase of less than equal to 10 days in length. Fourth, a low integrated progesterone level across the luteal phase. Now, clinical implications of luteal phase defect. First, infertility and subfertility. Second, first trimester pregnancy loss. Third, short menstrual cycles. Fourth, premenstrual spotting. Now, pathophysiology. The pathophysiology of luteal phase defect includes different mechanisms that ultimately affect endometrial development. First, short luteal phase. Short luteal phase causes low follicular phase FSH levels, low follicular phase estradiol levels, altered follicular phase FSH-LH ratios, and abnormal FSH and LH pulsatility. Second, these follicular phase abnormalities causes reduction in luteal phase estrogen and progesterone levels. Third, inadequate endometrial response to adequate hormone levels that leads to luteal phase defect and reduction in fertility. Fourth, idiopathic luteal phase defect. It is an abnormality of the luteal phase in the absence of an identifiable disease process. It does not cause infertility. Now, conditions altering the luteal phase. First, conditions that disrupt normal GnRH and LH pulsatility, hypothalamic amenorrhea, eating disorder, etc. that causes luteal phase defect. Second, thyroid and prolactin disorders that leads to disrupt GnRH secretion and alter the hypothalamic pituitary ovarian axis. Third, renal transplant, lactation, obesity, increased beta endorphin levels that leads to altered luteal progesterone levels. Fourth, advanced reproductive age that leads to abnormalities in luteal phase function. Now, diagnostic tests for luteal phase defect. First, menstrual cycle length. Monitoring the basal body temperature or urinary LH surge detection and monitoring the luteal length. Consider luteal phase defect when clinically indicated in the presence of a luteal phase of less than 10 days. Now, progesterone levels. First, a luteal progesterone value of more than 3 nanogram per ml is considered indicative of ovulation. Second, no minimal serum progesterone concentration defines normal or fertile luteal function. Third, 1 and 2 combined. Biochemical luteal phase defect. It is mid-luteal serum progesterone measurement of less than 5 nanogram per ml. Clinical luteal phase defect. Luteal phase of less than 10 days. Clinical and biochemical luteal phase defect were associated with lower follicular estradiol, lower luteal estradiol, lower luteal progesterone, and lighter menstrual flow. Fourth, endometrial biopsy. It was earlier considered as a gold standard to diagnose luteal phase defect. Now, disadvantages of endometrial biopsy. First, implantation depends on endometrial histology, steroid receptors, structural proteins, growth factors, cytokines, receptors, and pinopores. Second, a single endometrial biopsy may not be able to access global endometrial development. Third, no clinically applicable criteria are defined. Fourth, high viability within cycles and within reviewers for histopathology. Now, treatment of luteal phase defects. First, correction of an underlying condition such as hypothalamic or thyroid dysfunction, hyperprolactinemia. Second, empiric strategies. Improve ovulatory function, promote endometrial maturation, enhance endometrial receptivity, support implantation and development of an early pregnancy. These include first, ovarian stimulation and second, progesterone. Ovarian stimulation. The rationale is based on the physiologic continuity between the developing follicle and the corpus luteum, but ovulation induction is not advised to treat luteal phase defect. Second, progesterone. No evidence that progesterone is beneficial for treatment LPD. The role of progesterone supplementation for recurrent pregnancy loss overlaps with luteal phase defect due to inadequate progesterone support for early pregnancy. Thank you for listening. Thank you.